Okay, go ahead.
All right, thank you. My name is Tarek Loubani. I'm an emergency physician who works mostly in London, Ontario, but also in the Gaza Strip in Palestine. So I do lots of remote work, though I haven't done as much Northern Canada work as I would hope. I've really only been doing it for the last few years. So of course I have an idea of a remote context, but I don't have that great of an idea of your specific context. And hopefully that's something that we can work through together. We'll be talking about cold injuries today. So that would be hypothermia, trench foot, frostbite, frostnip, all of that stuff. I'm sure you guys have seen an awful lot of it. So we'll kind of get started and talk about it in a moment. First, though, I wanted to do a land acknowledgement. I myself am a Palestinian, which means that I'm very acutely aware of what it means to be an Indigenous person who's displaced. And of course, that makes it doubly painful to be a settler in another land and a settler who is displacing Native people. We're all based in different places, but I'm based in London, Ontario, as I had mentioned. And so I wanted to acknowledge that right now I sit on the traditional lands of the um, Anin- Anish, Ash, Anishinaabe, the Haudenosaunee, the Lenapehoik, and the Arawandaran. And I acknowledge that these treaties are specific to this area, the two-row Wampum Belt Treaty of the Haudenosaunee Confederacy, Silver Covenant Chain, the Beaver Hunting Grounds of the Haudenosaunee, the Nanfan Treaty of 1701, the McKee Treaty of 1790, London Township Treaty 1796, the Huron Treaty of 1827 with the Anishinaabe, and the Dish with One Spoon Covenant, wampum of the Anishinaabe and the Haudenosaunee. This land continues to be the home of diverse Indigenous peoples whom we recognize as contemporary stewards of the land and vital contributors to society. We hold all that is in the natural world in our highest esteem and give honor to the wonderment of all things within creation. This land acknowledgement is more or less meaningless except as a first step towards any kind of reconciliation. It's the work of all of us here to step towards decolonizing practices and bring our awareness into action. Of course, and I think all of us encourage everyone to be informed about traditional lands, treaties, histories, and cultures of the Indigenous people of this region and all the regions in which we are. So I would like to talk to you today about cold injuries, which really covers a few different categories. Typically, when we think of cold injuries, we think of hypothermia, or maybe we think of frostbite. And of course, those are important and distinct pieces of the overall whole. So I'm going to cover them separately as different units and then kind of come back and try to tie it together into what exactly you can do in your contexts. We have plenty of time, and I really don't mind interruptions, so please don't hesitate to interrupt me anytime that you want. And I'm sure that we'll have lots of time for discussion at the end as well. Okay, so I want to start by talking about freezing injuries. These are commonly known as frostbite or frostnip, though also there's a kind of immersion injury and the systemic injury called hypothermia that we'll talk about afterwards. The freezing injury cascade is sort of presented here. I'm really not going to do anything too special in terms of the science. This presentation's probably been given 1,000 different times by 1,000 different people. I'm not going to invent anything new or present to you anything that is outside of the norm of clinical practice here. So all of this is basically a summary of a couple of papers that are good reviews and also a chapter in Rosen's, which is the main emergency medicine textbook that we use in our center. This freezing injury cascade is a good way to start thinking about what exactly is happening when it comes to the damage of the tissues. So the pre-freeze phase, all of us, if we live in Canada and even if we live in anywhere that is mildly cold, have experienced this. This is the phase in which you kind of think of the frostbite beginning or these cold injuries beginning. So there's a kind of superficial tissue cooling. Your body is starting to respond in certain ways. The vascular contents are beginning to have problems like increased vascularity. And of course, you're starting to leak as well. None of these things are irreversible, and none of these things are in and of themselves dangerous, but they presage danger. They're on their way to danger. The real danger lives in the freeze thaw phase, and that's I think what we're going to be focusing on as something to kind of work on and avoid. As the blood is starting to freeze, um, well, as the tissues are starting to freeze, ice is forming. We often think of it being like the red blood cells that are causing the problems here, but actually it's not. It's not even really the blood that's causing the problems. It's the other cells that are basically forming into ice that are then pulling the water away and causing simultaneous kinds of injuries because of course you're feeding this freezing cycle with crystal formation with more water, and at the same time you're dehydrating the patient, causing all kinds of problems. So it's that water movement across the cell membrane that sort of starts the problem and really exacerbates it. And once that's happening, you're really starting to experience a lot of vascular effects. And this vascular stasis, progressive ischemia is kind of the third stage. In literal terms, this is where the damage is happening. Like, I mean, this is the thing where the death is happening. But I think of this less as causal and more reactive. This is more just kind of what's happening. Okay, so we think very often about frostbite as an entity. We've all heard about frostnip, but really these are part of a bit of a continuum. You want to think of frostnip as the first part of it and frostbite as the second part. Really, the demarcation line we're going to draw is reversibility. Frostnip, there is no actual cellular death, and frostbite, things are actually actively dying. So the distinction, if a patient comes in, patient comes in with a cold injury, you're trying to figure out what you're looking at. Um, Really, there are a few things that are good in terms of telling you which one it is, and a few things that don't really help that much. For example, discoloration. Frostnip, traditionally you say, oh, it's got some minor discoloration. But frostbite can have that minor discoloration too. So you have to be very conscientious that that uh, the injuries caused by frostbite can really come with any color, especially at the beginning. Of course, they evolve, but at the beginning, color is not a great way to distinguish. A better way to distinguish in practical terms immediately when you're assessing a patient who might still be in the cold injury is whether they have a partial anesthesia or a complete anesthesia. Are they able to feel anything? It's numb, it's tingly, but they can still feel it. Or is it gone? It's basically like you're touching it and they say, I can see you touching my hand. I can't feel you touching my hand or my foot. And of course, in a delayed phase, it's whether there's a return to normal sensation with rewarming. If the symptoms really don't get better, you're starting to rewarm the patient, then you're almost certainly looking at actual intracellular death, aka frostbite. This is a foot that was taken by like some person who ended up with frostbite on his feet, and it's tricky. So there's a few things that are kind of happening here. You sort of see it in the caption, but I want to really address this. This person is clearly still out of the field. You can see it's a photo taken in a car. And the discoloration is not yet something that clearly tells us what we're looking at unless we're very much aware of how frostbite looks. And what this victim is doing is basically saying, okay, well, I know I have a cold injury. Let's rewarm the foot. And so he's using dry heat in a car. Almost certainly he's just turned up the heater in the car and is trying to rewarm that foot. Um, it says there in the caption that there's a high likelihood of causing further damage. We'll talk about why that is in just a moment, because there are two parts to this. One of them is rapid rewarming. We want that, but the other one is we also want it to be done in a particular way that's not harmful. This one is really, really tricky. And I've seen cases exactly like this and followed them sort of a few weeks down the line. I think all of us will have seen this. Typically, a patient like this presents, they have been, for example, out in the bush for a while and then got stranded or didn't realize how bad things were until they started trying to remobilize and come back in, or they just sort of put themselves out for too long, or the other less typical scenario in the Canadian context, but still happens, is that the weather suddenly changed, they weren't able to extricate themselves, or they got lost, or something of this variety. Usually, if those cases happen, you're probably on a mountain or close to some very serious wilderness where there are people who don't know what's going on, who are around, like tourists and such. So in this particular image, there are some harbingers here of bad prognosis that we'll talk about. And ironically, the main one is that the foot looks more or less totally normal. That is to say, the foot is not responding to the situation. And this particular photo was taken after thawing. And so, it's not doing anything that we would associate with proper response. I wonder here if anybody has seen a patient with frostbite when they've thawed and some of the reactions and responses that feet have had when they've thawed.
Your AirPods case and press and hold the button on the case until the light flashes.
Sorry, can you say again? I didn't hear you very well.
I think that was just someone that had come off mute accidentally.
Okay, that's fine. So really the reactions, we'll talk about them in a moment, but they'll be things that you're relatively used to if you've seen any mild, moderate, actual frostbite cases. There are things like swelling, there's an injury. So there should be swelling if there's good vascularization. There are things like blistering, things like discoloration. This is a bit more typical of what we see when we recognize frostbite. So this particular image here is a very common one where if you're not careful, you might discharge the patient without appropriate care. Usually not a huge deal in most places because most of these scenes are relatively closed, but still, this is where mistakes happen. Here, it's much less likely you're going to make a mistake. You see the patient, they give you a cold history almost always. Even if they're found unconscious, you get a cold history, and then you look at their foot and it looks like this. I mean, I would say that very, very few of us are going to not know that something is wrong here. Classically, the mistakes that happened were thinking that these things were gangrene, et cetera, but that's much more typical of other kinds of injuries that are sub-freezing injuries rather than an injury like this, where almost certainly this person was out somewhere doing something unconscious or was unconscious, possibly intoxicated, and was brought in by some first responder or a good Samaritan. So the good prognostic indicators, I've just sort of divided them into favorable and unfavorable. Really, you want to see blisters. You want to see return of sensation. You want to see warmness to the touch. You want to see a return of color, any color, and you want to see some edema and swelling. These happen really a few hours. Think of it as really 4 hours plus. But in some patients, you'll notice that even by the time you see them, I mean, I'm guessing you guys have better physician initial assessment times than I do, but even by the time I see these patients 2-3 hours in after the injury, they've almost always started this process and you can see it. You think, oh, okay, that's good. If it's too early, I'll very often hold them for a few hours. They're often happy for a warm place, depending on the patient. For us in London, this tends to be more an injury of people who have addictions issues or have homelessness issues. So they're usually happy to stick around for a few hours. And then you can really assess the prognostication and whether they need sort of further management. On the other side of that, it's kind of the opposite. If you have this violet color that stays afterwards, I said, you want a return of color, any color, but black is a color, violet is a color. These are not colors you want to see. It does help you kind of prognosticate, because the parts around it will be a little bit more indicative of, okay, the skin is salvageable, or this limb is okay. But if you're seeing violet, if you're seeing black and dry eschars, that's bad. If after you've rewarmed the patient, they still can't feel or touch, then that's also bad. If the skin is literally frozen when you get to it, so I mentioned, usually we see people a little bit later on, but if you're sort of like trying to touch it and it feels like it's solid wood or a pack of cards or something like that, that kind of consistency, very hard rubber, that's probably bad, especially if you sort of try to take the skin and slide it and you're not able to move or slide the skin at all. So that's bad. Obviously, you look at this, like, that's bad. I don't think any of us would miss that there's a huge problem here. Almost certainly this patient is going to end up with amputations, and possibly those amputations go beyond just the level of the black eschars or the gangrenous areas. This is called dry gangrene, but I mean, it's really, I think the key there is that almost none of us are going to miss this, and this probably needs a plastics referral or consult. Usually by the time you see this, it's quite advanced. So this patient may have, like, obviously didn't immediately have black hands. They went through that progression, and they would have shown some of the other poor prognosticators before reaching this point. Usually this kind of a story will be a story where somebody is truly stranded, or something happens, they're truly unconscious, or trapped. For example, they're caught in a car that's in an accident, aren't able to extricate, there's prolonged extrication, or something of the variety of, they're intoxicated, and they were so intoxicated that they weren't able to feel it and stayed in cold contact position for some time. Okay, I think that generally sort of covers the how. In terms of what you do in a pre-hospital setting, there are some sort of common mistakes that people make in a pre-hospital setting. The most common mistake is people try to warm the limb. Unless you are in a place where you are guaranteed that there won't be any more cold, don't rewarm the limb. And this was an observation that was made in the Western world sort of 200 years ago, and other parts of the world even longer than that. It's that freeze thaw that is super destructive. Also, don't directly engage the tissue. So there's a thing that's still practiced in many places, even in Canada, called an ice massage or a snow massage. So the idea is that friction is helpful even if it's ice. I mean, it's not as crazy as it sounds on the face of it, because if you've ever done this to yourself, if you're in a frost nip situation, it actually works. So, if you're ever out and kind of get stuck, and you're in a situation where you're still not super cold, you can friction rub almost anything on your hands, and it'll result in some rewarming. And so that was the rationale that led to people doing ice massages, or even general just sort of massages with their hands. The problem is that this is very friable, leaky skin with lots of problems in the subcutaneous tissues, and doing these massages is just going to increase the amount of damage that happens. In terms of the things to do, there's really only two big things to do. One of them is remove the wet clothes, and the other one is remove the any kind of restricting clothing. You want the limb to be able to swell so that it doesn't basically the clothes don't create a tourniquet or a tourniquet effect. So these are the two main things. Obviously, if somebody's in hypothermia, then you go into life over limb, but this is with the assumption that there isn't sort of systemic issues in the pre-hospital setting. In the hospital setting, I always kind of divide it into three big things. What do you do before you start thawing the patient? What do you do in terms of thawing the patient? And then how do you disposition them? In terms of before the thaw starts, the way that I sort of think of it is, you're always in a life over limb situation. Nobody's gonna, well, I mean, I don't know, maybe somebody will, but generally people won't thank you for saving their limb and letting them die. So yes, you do want to save the limb, but if you see systemic features and the patient is in need of resuscitation because they're hypothermic and acutely at risk, then do not hesitate. More or less ignore everything we talk about with extremity and what are called freezing or even non-freezing injuries, and just go for the resuscitation. And we'll talk about that a little bit more. So resuscitate the patient first, make sure they're stable first, and then start thinking about their limbs. In terms of what to do, let's say you've passed that stage, they're resuscitated. Oh, and by the way, in terms of resuscitation, they're almost always, in this case, going to be dehydrated. So you want to start thinking about how to rehydrate them safely, and make sure that they're getting lots of fluid. Hypothermia in general and cold extremity injuries specifically are pulling fluid out. It's one of the features in general for reasons I'm not going to get into that much, but that have to do with some of the pH changes and shifts. But water is getting constantly pulled out of the body when people are cold. In terms of how to thaw them, the key is make it fast. There were I think classically we were all sort of told like, oh, you do slow rewarming of limbs. And this really, when you think about it, is a mixing of what to do about systemic hypothermia and what to do about cold freezing and non-freezing injuries of the limbs, the non-core. Yes, your core is often affected with these injuries. It's not like somebody is going to have a totally frozen hand and absolutely nothing, but you're not always in a resuscitation situation where you should slow down the warming. So don't hesitate. You can just go right ahead in terms of the rapid rewarming. And you can do it more or less any way except blowtorching the thing. Don't light the thing on fire. Don't basically point something that's going to cause a heat injury. Anything that is 40 degrees and above will almost certainly cause a heat injury. Don't do that, especially in these patients who can't protect themselves through vasodilation. So if it's 40 and above, don't do that. Think about 37 to 39 as the main temperatures that you want things to be. So for example, very practically speaking, in some of the remote areas that I've worked, this would mean taking warm blankets out of the warm blanket area, taking these forced air sort of blankets and using them to also rewarm the patient, or circulating warm water on the patient's limbs, so either on their hands or on their feet. Warm water, basically, if it feels uncomfortable to you, it's too hot. Most of our taps will go up to, I think it's about 45 or 50 because the scald temperature is around there. So instant scald, I don't remember exactly. I think it's around 50 degrees Celsius. So you want to be well below that in the 40-degree range. If you put your hand in and it's uncomfortable for you, it's probably hotter than 40 degrees Celsius. And then, of course, after you rewarm the patient, you want to start thinking about disposition. Where are you going to send the patient? What are you going to do with the patient? How are you going to get them moving from the department? Okay, so that's basically freezing injuries like frostbite. I'm going to also talk about some immersion injuries. So, for example, classically, immersion injury would be something like trench foot, or you can actually even have a dry injury, which is called pernio or chilblains. These are names that are much less common for almost all of us. But having said that, you do occasionally see these dry, non-freezing injuries. Before we get too much more into that, any questions about the frostbite or any comments about the frostbite from your own experiences? Okay, and I can't quite see if there's comments in the chat from this particular view, unfortunately. So don't hesitate to write whatever comments you want in the chat if you wish. And Marika, if you don't mind kind of monitoring and letting me know if there's any comments that come up, or anybody else can jump in. So for non-freezing injury management, this one's a little bit different. If you don't think that there was a freezing injury, so What's the difference? The difference is, was it below 0 or was it above 0? Was there ice? Was there not ice? If, for example, you're in a place that is 10 degrees Celsius, you will eventually get a non-freezing injury, especially if it's only really the limb. The body is shutting down some of the peripheral circulation. So if a person is cold, then they may end up with problems in their arms or legs. And those issues that arise, they usually will benefit from slow rewarming. So more typically, we used to see this. I mean, the idea of trench foot comes from World War I and that era. So the idea is that, you know, these are people where they couldn't get their boots dry, they couldn't get their boots warm, and so they would basically just be sitting there in water that was 5 degrees Celsius or 10 degrees Celsius and wouldn't be able to do much about it. And here it's it can be bad. Trench foot can be quite bad, especially because of the progression, and it's all the same kinds of prognostic indicators that we were talking about before. But the only real distinction is that you want to slow up the rewarming rather than speed it up. The main distinction here is historical. It's almost always subacute. It's almost always, you know, people telling you that, well, I didn't realize that I could get injured from this level of cold. Like, I don't know why this happened. And it's those kinds of things you want to keep in mind, just to listen in for. There's also sort of things that are going to predispose you in that direction. And this is also now shifting us in the direction of hypothermia. So we're going to start talking about hypothermia as well. But of course, these things apply to the other injuries that we talked about as well. What is hypothermia? Hypothermia is when you're cold systematically. There are numbers that you can assign to it. Everybody kind of has their own number of when they consider hypothermia to have really set in. I think a good rule of thumb is that if they're 36 and below, then that is hypothermia. And really anything higher than that, you can kind of use your discretion. You should definitely rewarm them, but how exactly you diagnose them is a matter of some personal preference. So the things that are going to encourage, I see somebody's come off mute. Did you have a question or comment? Okay, keep going then. So in terms of the heat loss, these are things like conduction, convection, radiation, respiration, evaporation. These are like classic ways that people lose heat. Almost always radiation is the main factor. So for example, when you're walking through this world with your jacket in winter, then you are really talking about radiation being the main mechanism. The moment you get wet, the moment a patient gets wet, everything changes, and it is now basically a conductive heat loss. And we're talking, usually radiation accounts for like 50% of most of our heat loss. But the moment we get wet, then conduction basically takes over and will go from 2 to 3% to something like 75% of the heat loss. And that's why you want to get people out of wet clothes, because you want to change them from a conductive heat loss to a radiative heat loss, which is much easier both for them to control and for you to control with your environment. So these are the ways that we lose heat. How do we gain heat? And this is indicative of the things you can do if you're stuck in a situation to try to prevent the onset of serious hypothermia. Food ingestion is a really common one. You're like, when you say calorie, you're talking about the amount of energy it takes to heat up water. So of course, we're burning a tremendous amount of energy in an almost literal sense when we consume food and ingest food. Muscle activity is a very common one. So, you know, when you're rubbing your hands together, of course, there's friction, but there's also the fact that those muscles are firing off. Fever is a mechanism that also works, but has lots of issues that are associated with it. Shivering is a very good one that can increase your basal rate by, I think it's 5 or 6 times, 500 to 600%. Vasoconstriction, we've all known that and felt that. The moment you get cold, your hands basically start to become colder because they're vasoconstricting. And that's your body understanding the life over limb concept. hypothermia really is, we sort of look at all of these factors, and hypothermia is important, but it's not quite as important as we think of it. We really love to talk about hypothermia, even though lots of the disability and morbidity is happening from the other cold-related injuries, because hypothermia is dramatic, and because we've all heard fabulous stories about hypothermia survival. So for example, one of my colleagues in some international work that I do is the resuscitationist who had worked on a 29-year-old doctor for, I think it was, I forget the exact number, I think it was 13 hours. And she had almost complete recovery of function. When she was first found, her temperature was like 3 or 4 degrees. She was a submersion injury, so basically had gotten stuck under ice, had an air pocket, so she was able to breathe, and then finally succumbed to hypothermia. When they were able to break out the ice, her temperature, her core temperature was, I think actually 9 degrees was what they caught it at. No, sorry, 13 degrees is what they caught it at. And then they rewarmed her for literally 13 hours until she came back. So you hear stories like that, and you start thinking like, okay, well, I can never let anybody who's cold die. And that's where sayings like nobody's dead until they're warm and dead. There are also some like dramatic stories of people coming back to life in the morgue and things like that. So you do want to be cautious, but at the same time, that's not the usual outcome for patients who come in who are frozen and have rigor mortis and so on. So there are some distinctions. I won't make them here today unless you guys want to explore them. But there are some distinctions as to what makes it a little bit more survivable or less survivable in the resuscitative case. I think what we're more likely to talk about here today, and what's more likely to be useful, is just regular old systemic hypothermia. So basically, I kind of think of hypothermia as, or the hypothermia body response is kind of dividing into these 3 main categories. The first category is what we all think of when we get cold. It really takes us down to about 30 degrees of body temperature. Vasoconstriction, shivering, non-shivering, basal and endocrinologic thermogenesis. So your body is doing all these things to try to bring your temperature back up, and supposing that this is in the, I guess technically it would be in the moderate category here, then you're probably going to be able to get your way out of it so long as the temperature is able to be corrected. Once you go lower than that, then you're talking about sort of metabolic changes that are happening without shivering. At the same time here, people are starting to really display confusion. They're having lots of CNS effects. Your body is responding by trying to lower your basal rate. This is the phase where, if it's prolonged, a person can survive. So if, for example, you're in water and it's taking you down relatively slowly, your body is able to get into kind of a reduced basal rate, people will have profound bradycardia. So in the 37 to 30 stage, almost all of us will have tachycardia. And then once you go 30 and below, as you're getting your basal rate depression, people will start to get these cold reflexes. And one of them is profound bradycardia. Like we're talking about rates as low as 4 per minute, or something of this variety, even 2 per minute. So you're really talking about very low rates. One of the weird things that also happens here in this rate between sort of 30 and 24 is diuresis. I read about the mechanism. I don't remember exactly what the mechanism is right now, but suffice it to say, you're going to diurese at these temperatures. And this is one of the mechanisms of dehydration. So these patients are very often dehydrated. You have to kind of be super aware of that. And for us, I know in the emergency, we love putting monitors and leads on people. And so you do see some other CVS effects on ECG. I would sincerely caution people on using the ECG to direct their management or their care. there's a thing that like we all kind of learned in med school called the Osborne wave or the J wave. And you'd always kind of be told like, oh, you know, if your patient gets a J wave, well, then you should treat them differently. You should do this or that or the other thing. But really, at least from my reading, I kind of went into this lecture sort of thinking like, oh, okay, you know, I'm sure that there's some information on what are prognosticators on ECG. I couldn't really find anything useful at all. And that kind of echoes my experiences and the experiences of other people I talk to, which is that you got to go by the physiology, not by any of these diagnostic indicators that we think of like ECG. Obviously, if they are having an ST elevation MI or something like that, then you have to think about it a little bit differently. That can happen because sometimes vasoconstriction can, in a person who already has systemic illness, can end up causing other issues. And they can also end up with heart attacks because of the increased viscosity. They can end up with PEs because of the increased viscosity. So you got to be really, really cautious about that. There's a legend that kind of goes around in the far north when I'd worked kind of in northern Quebec some years back, that people who are native to those areas, they just don't get increased viscosity of their blood. So they never get PEs, they never get, you know, sort of coronary thrombosis and so on as a result of hypothermia. I don't really know. I'm not sure that there's any like systemic study of that. So I would say just think about it and think about sort of what needs to happen for that patient in each of these stages. Once you get below 24 degrees Celsius, basically nothing works. In terms of the body is no longer able to respond in any meaningful way. I had mentioned some of the characteristics. I'm really not going to spend all that much time on this particular slide. It's a busy slide. It's been sent to you. It's nice. I just pulled it out because I look at it every once in a while. I just kind of have it saved to my phone. And if I'm seeing some sorts of reactions that are discordant, the most useful thing of this table in clinical practice is if I'm seeing things that are discordant, then I'm looking for concomitant systemic disease. So for example, you might have somebody who's profoundly hypothermic and you're trying to rewarm them, things are happening, they're up to 33, 34, they're still stuporous. Like what's happening here? You've probably missed a hypoglycemia. So there are systemic diseases and they confound each other. If you have a systemic disease, it'll make hypothermia worse. If you have hypothermia, it'll make a systemic disease worse. And so you want to be aware if you're sort of looking at a patient, for example, who's 35 degrees Celsius, like not shivering, not conscious. No, it's not hypothermia. Yes, it technically meets the definition of hypothermia, but no, it's not hypothermia. Start thinking about something else. So I'll sort of move on from that. I talked a little bit about some of the pull of the water and how your diagnostic tests aren't a good way to lead you. Especially be cautious of blood gases. There's a practice that we have in almost every center that I've worked at in the last couple of years where we love blood gases now, and we love to treat pHs. Be very, very cautious because pH changes. The pH of water, for those of you who have done some more advanced chemistry, the pH of water really is at 25 degrees Celsius. That's why this dot right here, I guess I can kind of point at it. This dot right here is at 25. Other than that, the pH is changing depending on the temperature. So you really do want to be somewhat aware of the fact that you shouldn't be directing your management to blood gases. You shouldn't be directing your management to ECGs. You should be directing your management more or less to this, to the characteristics and to their temperature. So the management, this is probably the management that we do on almost anybody who has any kind of cold injury. I find we do a great job of rewarming people's body core. We don't do an amazing job of rewarming people's limbs, but generally you want to take the patient first, think of general resuscitation, ABCs. If you need to intubate them, go ahead and intubate them. Intubation in profoundly hypothermic patients is a little bit harder depending on how frozen they are. If they're so frozen that you're having trouble with their vocal cords, they're probably already deceased. So yes, go through the motions of making sure that they rewarm fine and that you have some resuscitation. But if somebody is literally frozen solid, then I think for most people on this call, it is not practical to consider that person survivable. The only time that people have survived, you know, when you're talking about 13 degrees and things like that, are with really serious, prolonged, multi-team resuscitation. That's practically speaking just not going to happen in most of the communities where there's one or two of us there. And it's probably reasonable to allow them to rewarm in the bed and to see if anything changes as they're relatively passively rewarming, but to consider them more or less deceased at that point. However, if the person is kind of on the verge, you sort of see some electrical activity on the ECG, but you don't have a pulse, consider them an active patient. Do ACLS, you know, rewarm them, do all of the things. Warmed fluid is ideal. I'm entirely sure that almost none of you will have available to you fluid rewarmers. So just make sure that, especially sort of, I think of it from September to April, there's fluid in the blanket warmers, and you kind of have 1 or 2 bags of saline. Infectious diseases hates this. Infection control hates this, but I mean, like, come on, it's probably fine. And if the person is dying, you can give them antibiotics after. In fact, ironically, one of the main sort of systems of hypothermia management does say that all of these patients should receive antibiotics on spec anyway. But, you know, you can just add that to what are the reasons why you give them antibiotics. Cardiac medications are especially useful if you're at that threshold where their heart is about to stop and you're seeing it do weird things. It's going tachy, then brady, it's flipping into VTAC. They're becoming pulseless as you're kind of going along. And then for rewarming, really, like, I know people, it's almost like religions. People are like, oh, you have to passively rewarm these. You have to actively rewarm these. This is not like extremity injuries where there is a right answer. There's no right answer. Just rewarm them. If it's passive, if it's active, if it's internal, if it's external, it doesn't really matter. Do you have an ECMO handy? Sure, put them on ECMO. Do you have peritoneal dialysis right there? Fine, put them on peritoneal dialysis. But if you don't, all you can do is put a bear hugger on these forced air blankets, then don't worry about it. Just put the forced air blanket on. It's fine. And if you wanted to do something more active, then that's fine too. I personally, the way that I approach this, I always put the bear hugger on. I always start with the warmed fluids, and then I start thinking about what are some of the other ways that I can rewarm this person. Some centers where there are frequent cold injuries will have a spa type thing or jacuzzi type thing where you have recirculating warmed water. That's the most ideal. Keep their limbs out and rewarm their core. Okay, I think we may stop there in a moment. I think that's pretty much it. I do want to take a quick moment just to talk about coagulation. You know, when the blood is cold, it is both more viscous and less coagulable. So it's kind of this really weird nightmare scenario that you're dealing with. So just be aware of that. And I want to just put another shout out again to acid base problems. Ignore more or less, unless you think something else is going on, there's another diagnosis. Ignore that blood gas. It's not going to help you. Just rewarm clinically. Okay, I think that's it. Yep. So we'll stop there for some questions. We have 15 minutes. Are there any questions, comments, or even if you want to share some of your experiences, I think that would be really valuable too.
I do have a question. Just for some context, this is all very, very new to me. Thank you so much for the presentation. When it came to extremity management, you mentioned that there was a gold standard. Are extremities meant to be completely submerged in water that's 37 to 39 degrees, or just like partially with warm towels, that kind of thing?
Yeah, the gold standard is not the how, but the what. It's rapid rewarming. So that's the main standard. And the reason why we mentioned that is because, oh, and it's also no touch rapid rewarming. So you don't go there and rub the skin and so on. If you submerge it in water that's 37 to 39, great. Like you're doing exactly the right thing. That is rapid rewarming. If all you have available to you is forced air, that's okay too. But just watch out for some other issues. I think if we had to pick like one gold standard, it would be submersion in 37 to 39 circulating water. Because remember, if it's standing, it's just like putting ice cubes in there. It's going to cool, it's going to become less useful, and your rewarming will happen significantly slower. What's your, I'm guessing your name is Sydney. What's your context, Sydney? Are you a physician or a nurse, or what's your context when you say you're new to this?
I'm going to be a nurse starting up north in Ontario for the first time, going up there for the first time.
Okay, amazing, congratulations. And I think that for these injuries, yeah, you're probably going to be dealing with more extremity injuries, freezing injuries and non-freezing injuries than you will with hypothermia. It's very similar to like how I work in the Middle East. In the Middle East, we don't have that many people who have specific heat stroke because everybody kind of internalizes a culture of how to deal with that. But mistakes happen, problems happen. You will see hypothermia, and you'll definitely see extremity injuries as well. So I think it's just that rapid rewarming, warm circulating water if you can, and kind of go from there.
Thank you so much.
No problem. All right, any other questions or comments, concerns? Are there any cases that people had where things got tricky or they were atypical hypothermia cases? All right, while people are thinking about it, I'll talk about one case that I had, which was very tricky, and it was a hypothermia case in a child. And basically, unbeknownst to the parents, there had been some water that fell. The temperature of the room was about 14 degrees Celsius, 13, 14 degrees Celsius. Some water coated the bottom of the bassinet, and the bassinet was plastic coated, in case there was some kind of accident from the baby. And essentially, because of the conductive heat loss, the child came in profoundly hypothermic. Children become hypothermic faster and sooner because they have less surface area for their weight, or sorry, more surface area for their weight comparatively. So there's a lot, if it was a radiator, their radiator is much bigger than ours, the amount of surface area that they had. And this was a case where it was very hard for the parents to understand how the patient became hypothermic. For us, really, it was hard to also know, like, well, where's the patient on the hypothermia spectrum? What do we do in terms of rewarming this particular child? At the end of the day, that particular child deceased, unfortunately. It was just sort of too far along, but it was really difficult to sort of consider and think about those resuscitations, what to do, when to do it. It was a non-freezing hypothermia, so that's, I would say, in Canada, that's the most common misconception. People will be like, well, I mean, but we weren't out in the cold. Well, yes, but 15 or 16 when you're in it for hours is cold, and 15 or 16 when you turn from radiant heat loss to conductive heat loss can kill you.
I have a question. We had a client in one of the communities, and he had run out of the house in the night barefoot. There was snow, it was cold. And he presented to the clinic later that afternoon, and both of his feet were quite frostbitten and severely blistered and edematous. And we had trouble because he was obviously walking on them. So we weren't quite sure how to manage the blisters. Like, should we have debrided, or should we have, like, once we rewarmed, because he was going to be walking on them anyway, it was quite painful. I'm just, what's your take on debriding versus, do you leave the blisters, especially on the soles of the feet?
I think the blister issue is not specific to hypothermia. Usually by the time you've got blisters, you're in the rewarming phase and hopefully there isn't going to be a refreeze. In terms of general blister management, I hesitate to say there's a clear winner. I never debride them because I think it increases the rate of infection. However, I know lots of wound care nurses who love debriding them and think that that's the best way to proceed. The way that I think it could be evaluated in a case like this is, what do you think is more likely to lead to patient compliance? So for example, sometimes with these patients, you know you're never going to see them again. You know they're not going to care for that blister. So debride it and dress it and see what happens. If somebody's able to care for their blisters, I would leave it as long as possible. So my more conscientious patients, people who have cold injuries or burn injuries, who are conscientious, and I think usually like workers who something happened at work, usually for them, I'll leave the blisters on. I'll tell them to leave the blisters on until the blisters start to go away on their own. They'll degrade over time, of course. And you really want, as much as possible, the underlying endothelial layers to rebuild so that when the blister breaks, there isn't a direct pathway for infection. So it's a tough situation. It sounds like this is a non-compliant or potentially non-compliant patient who's capable of doing some things that I might consider irrational. In a case like that, I think if I had to, I would, if I had to deal with that patient, I would cut the blisters and dress him and then see what happens. What did you guys decide to do in the end?
We ended up debriding just because we have high rates of MRSA in our communities and lack of running water in the majority of houses. So we were worried that the blisters would pop on their own and then just harbor more infection. But we found it quite hard to debride because the skin on the sole of his feet was so thick. And then it made his pain level worse because it was just exposed tissue at that point. So it was hard to manage. He did end up getting like infection, and we had to start him on some antibiotics as well. But
yeah, it's a toughie. There's really no right answer on that one, because of course your rate of infection will go up once you debride it, because you've taken away the layer there to kind of protect them. At the same time, a badly cared for blister, just like you noted, will do very much the same. So I think you're kind of caught. I don't think there was a right answer specifically there. The right answer in patients who are conscientious, leave it. And I think if it's super dirty, then maybe debridement makes some sense if you don't think you can clean it well enough.
thank you.
No problem. Sorry, I have to do some management here of my own on this little hypothermic one. All right. And any other comments or thoughts? Okay, well, thank you guys so much for joining. It was really a pleasure. I don't know who you guys have as resources, but don't hesitate to reach out. I'll make my information available as well. And that's not just for hypothermia related stuff, really anything that you need, I'm very happy to help out with.
Thank you so much. We appreciate the time.
All
Thanks,
right,
everybody. Have a great day.
bye.
Bye.
Thank you.